I'm Dr Matthew Fay. I'm a GP who works in Shipley, which is just north of Bradford, and I'm a GP with a special interest in cardiology. When people come to see me with heart rhythm problems, they have about 10 minutes to discuss their issues. I really like things like the heart rhythm checklist because it allows patients to organise their thoughts and prepare for the consultation. I would hate to think that we see the consultation as an exam process, but being prepared for the 10-minute slot does help us work through their problems better and hopefully come up with a better conclusion about investigations and possibly onward referral. Prior to becoming a general practitioner, as was the fashion in training of the day, you could do many different subjects prior to starting a GP training. I was lucky enough to work with a cardiologist as a houseman and an SHO that developed an interest in this area. When I became a general practitioner, I continued to pursue this and found that arrhythmias were not quite as well served as people with angina and heart failure. This led to a development of an interest, initially in palpitations in general, increasingly around atrial fibrillation, and now even more so in trying to prevent the devastating stroke that AF can cause. When patients come to see me, I always have to think, can I deal with this person's problems? Now, sometimes they can be easily treated with medication and investigations available in general practice, and I would do my best to try and treat the patient locally and within my skills. However, occasionally we see patients who require a referral to a rhythm specialist for further more detailed investigation, and I do this on regular occasions. Increasingly, I feel that the treatment of atrial fibrillation should be treated in two ways. One is to try and prevent the stroke that AF carries, and that can invariably just require an adequate assessment and referral for anticoagulation, and I feel the general practitioner should do that role. If the symptoms are disturbing, then they need to be properly assessed and see if more invasive techniques can resolve symptoms, and they need to see a rhythm specialist, and I happily refer them on to my colleagues. When patients come to see me with their arrhythmias, they're usually talking about palpitations, the sensation of the heart beating in the chest, maybe vigorously or rapidly, or sometimes in an uncoordinated way. However, I do see people who come to see me with fatigue and breathlessness, where on closer discussion and examination, we find that they are also suffering from rhythm-related problems, and we have to try and clear these through to make sure we get the appropriate investigations to identify their underlying rhythm problems. If somebody's experiencing symptoms that they think may be due to a heart rhythm problem, I think they should respond to them on how they feel. If they feel extremely unwell or extremely anxious, then they should call a paramedic and get themselves to hospital. However, if their symptoms are brief, then they should arrange to see their doctor at the earliest opportunity so they can discuss them in detail and make sure we get the appropriate investigations performed. When the GP is caring for somebody who's been treated for an arrhythmia, possibly with ablation therapy or the insertion of a device, often the patient will actually have more information than the GP. The role of the general practitioner becomes that of support and a very rapid conduit back to their consultant or specialist to make sure that any issues are dealt with. Sometimes, of course, it can just be the normal anxiety that we see after any procedure, and GPs can deal with patients suffering symptoms of anxiety reasonably well, possibly in talking therapies or, if needed, simple medication. When the general practitioner sees somebody who's complaining of symptoms of an arrhythmia, invariably the patient is actually in normal rhythm at the time. And this then becomes the hunt to try and find what the problem is. Now, some general practitioners may choose to just refer on to a specialist like myself in general practice or to a consultant cardiologist to have this investigated, and some may choose to do tests themselves. The absolute basic test is the need for an ECG, interpreted by a doctor who understands what they're looking at. Following this, many of us would try to risk stratify the patient. So a young person with a normal ECG is unlikely in the first instance to have a dangerous arrhythmia. However, the older person with complicated heart disease is much more likely to have something significant that needs prompt attention. It would depend on the risk that that patient is carrying to how quickly the general practitioner will move that person further in the referral chain. I think it's important to say that all general practitioners are not the same. We all tend to have our own areas of interest and our own capabilities. So you may find that where one general practitioner refers very promptly for assistance from a cardiologist, another general practitioner, well within their capabilities, may choose to do further investigation to try and speed the process once the patient is referred. I think that there is a real question about certain arrhythmias that should be looked for in the general population because they are clearly common and they clearly carry risk. I would like to see the screening of atrial fibrillation in the older population, the over 65s, because we know that 1 in 10 people will be suffering from atrial fibrillation. We know that the majority of them will be at risk of stroke, and we know we have an excellent intervention to reduce that risk in the form of oral anticoagulation. I think this fulfills the criteria to say that we should be screening for this problem in the patients who are at risk.